Welcome to our webinar this afternoon. This is November 2nd, 2020, the day before the voting for the United States president. Everyone's very excited, and we're very excited to have you with us participating in this webinar. We're very grateful to our corporate sponsors, Bristol Myers Squibb and the American College of Chest Physicians, for bringing us together to discuss the topic today, which is the role of immunotherapy and multidisciplinary tumor boards in the management of late-stage non-small cell lung cancer. My name is Eric Edell. I'm a pulmonary physician and professor of medicine at Mayo Clinic in Rochester, Minnesota. And I'm honored to have with me two experts in the field of medical oncology. And I'm going to ask each one of them to introduce themselves, tell me where they're from and what they're doing at their home institution. And then I'd like to ask them the one positive that the COVID pandemic has provided for them. Dr. Duma, why don't you go first?
Hi, everyone. My name is Dr. Narjust Duma, and I'm a medical oncologist, like Dr. Edell mentioned, and an assistant professor of medicine at the University of Wisconsin, and I specialize in women with lung cancer. In July 2020, we opened a clinic dedicated for women with lung cancer at the University of Wisconsin. Something good about COVID-19. I forgot what I said last time, but I think it has been a great opportunity to go back and read all books. So I'm reading the books that my favorite books when I was 17 and 18. So I found those books in Spanish and I'm reading them all over again and falling in love with the same writers. So that has been a good thing about this quarantine time.
Fantastic. Fantastic. I can resonate with that. Dr. Besvina?
So my name is Christine Besvina. I'm a thoracic oncologist at the University of Chicago. It's great to be here with everyone today. I am an assistant professor. I see only thoracic diseases, so non-small cell, small cell, and thymic. The good thing about COVID is that about 2 weeks into Chicago being on lockdown and quarantine, I convinced my husband to allow me to get 2 COVID kittens. They are our COVID comfort kittens. And so it's been really fun to actually have some fuzzy friends at home now. So I can say that we capitalized on physicians working from home appropriately.
The one thing I would like to add to these wonderful comments is in alignment with what we're doing today. And I have to say that one of the positives that have come out of COVID for me is the connection with colleagues using this technology. So I hope that the learners will also embrace, even though this is a challenging environment, it's enabled us on some levels to see each other actually more frequently. It also has helped with us here in Mayo anyway, and I'm sure other places, for our multidisciplinary tumor boards to include more people. We generally would have a handful to maybe 10 to 12. We're having now up to 25 to 30 people participate in our multidisciplinary tumor boards, which I think is fantastic. And finally, and I think Dr. Duma, you mentioned this one last time, was the telemedicine component of what we're doing with caring for these patients, and telemedicine has been significant. So what we'd like to do now, we'd like for this to be as interactive as we can. You can see there's Q&A on Zoom. I'm sure many of you that are attending are very expert. We want you to answer the questions. We're also going to make it as interactive as we can with the format. The format is case-based with audience response. So please respond to the polls when they come out, and then we'll stimulate the discussion around that. So if I could have the next slide, this is all of our disclosures. Just give you a minute to review that. I'm not going to read it for you. Next slide, please. And these are the 2 objectives. You can see they're basically what we described in the title of the talk. And hopefully at the end of this, you'll be able to gain more information from our expert panel regarding the management of these very challenging patients. So without further ado, can we have the slide for the first case, please? So we'd like for you to think about this. A 76-year-old man, smoker, low back pain. CT scan unfortunately demonstrates a destructive lesion. I'm not going to show you the x-ray for the sake of time, but you can imagine what we're talking about. So next slide, please. What we want you to contemplate is, what would you do next? Not necessarily a right or wrong, but please vote. What would you do next? Bronchoscopy with biopsy of the primary lesion, CT-guided biopsy of the primary lesion, biopsy of the L3 lesion, or bronchoscopy with EBUS sampling. The poll's open. I see we have a small number of attendees, but that means high quality. And maybe we'll get some interaction. Don't hesitate to answer. As we said, these are intended to stimulate conversation. Okay, let's take a look and see what we have. So here's the distribution. Dr. Besvina, what do you think of the audience's response?
So I am a little interested in the distribution. So the least popular answer was CT-guided biopsy of L3. And we'll talk about in a second why that may be the preferred answer here, which is that would allow us to confirm both stage and diagnosis in the same procedure. We also had CT-guided biopsy of the primary lesion. I think that would be lower on my list. I have a higher likelihood of getting significant tissue with bronch as opposed to CT-guided biopsy. Bronchoscopy with EBUS sampling, or bronchoscopy with biopsy of the primary lesion. And again, I just want to point out here that the patient had a pretty convincing L3 lesion. So let's go ahead and switch to the next slide to discuss.
Not just yet, Carla. I just want to ask Dr. Duma, what do you think about doing the biopsy of the L3 lesion?
Well, I think, as Dr. Besvina mentioned, it provides you the opportunity to stage the patient, but we also need to mention one of the limitations about biopsying bone, and is that as you biopsy bone, you have to decalcify the sample, and you may lose DNA, which we know allow for genomic testing, which is essential for lung cancer diagnosis. I think the lung cancer diagnosis is not complete until the genomics are resulted. So I think it's important to take into account, but it is the right option because we always have to hope to stage the patient.
And I just would add, I think it's often that we'll have an opportunity for soft tissue around some of these. And depending upon the skill of the interventional radiologist, it's sometimes possible to get a biopsy without the tissue. So, okay, let's go to the next slide. And this is the guideline that illustrates exactly what both Dr. Besvina and Dr. Duma articulated. And you can see it's expressed in most, if not all, guidelines that we have in managing late stage particular non-small cell lung cancer. Okay, next slide, please. So they went ahead, and not surprising, this was positive for squamous cell carcinoma. There were no actionable mutations identified, and you can see the PDL expression. Next slide, please. So now with that information, what would you do next? You can see the multidisciplinary tumor board, platinum-based chemotherapy, surgical consultation, or immunotherapy. And you guys can vote, please. I like active participation. They're jumping right in. And if any questions come up, those of you that are in our audience, don't hesitate to send through a question and we can ask as we go. Okay, Dr. Besvina, what do you think?
So the least popular answer was surgical consultation. Next least popular was platinum-based systemic chemotherapy with immunotherapy. I think that actually would be my preferred next step. We've confirmed that this patient has stage 4 metastatic squamous cell carcinoma, so standard of care would be chemo IO for this patient. One respondent chose immunotherapy alone. That's actually not technically wrong by NCCN guidelines. You can give Keytruda alone for anybody who expresses PD-L1. I think the majority of us, though, feel that this benefit is in the higher PD-L1 patients and would prefer a triplet in this medium range. The most popular answer was multidisciplinary tumor board, which I think would actually be what would happen at our institution at this time. A lot of these oligometastatic patients were being pretty aggressive from diagnosis and considering the role of radiation early on. So I think that also would be a part of our treatment plan after chemo-IO.
Dr. Duma, anything to add?
I agree with the point of the multidisciplinary tumor board, because when you're able to put a pulmonologist, a radiologist, a radonc all in the same room, you can come out with new ideas or a more holistic way to incorporate the patients. And our tumor boards, we often have palliative care as well. So we're able to set up the palliative care referral right away. He may have pain, and we know that patients with lung cancer live longer if they have an early referral with palliative care. So, and in all honesty, to everyone, I think the benefit of the tumor board in this time in which we are isolated, we're closer but apart at the same time. I think I look forward to my molecular, the molecular and the lung cancer tumor board. We have two different tumor boards, just to connect with colleagues and make sure we run not only the cases to be presented, but follow-up cases as well, because you always learn and you get to connect with that person and follow-ups, how some patients are doing.
I just want to highlight one comment that Dr. Duma made, and our audience may be familiar with this, but there are two randomized controlled trials between standard care with and without palliative care. And those studies both showed, as Dr. Duma said, an improvement in not only survival, but quality of life of both the patients and the family. So having palliative care on board is right on. We need to have that right away. Dr. Besvina, would you like to then go through the slides that support your first answer in the issue of how we manage these stage 4 cancers now in the world of immunotherapy?
Absolutely. Carla, do you mind advancing to the next slide for us? And so the next few slides are going to break down how we think about systemic therapy for stage 4 non-small cell lung cancer patients. And so for patients who have a high level of PD-L1 expression, which we define as 50% or greater, Keytruda or pembrolizumab alone is, for many of us, the preferred therapy. You could still consider triplet therapy of carbo-pem-pem or carbo-taxol-pem or any of the ipi-nivo chemo combos that we'll talk about in a second. But I think the large majority of us, unless there's a reason why you feel a chemo-IO combination is required, would favor starting with immunotherapy alone. We've seen some pretty dramatic and prolonged responses in this patient group. Next slide. You have more options for the patients who are in the kind of intermediate range. So I'll focus here on for patients who have PD-L1 of 1 to 49%, although again, these options are allowable by the FDA for high expressors. We have a lot of options now in the frontline setting, which is very exciting compared to what we had, 2, 3, 4 years ago. For these patients, you can consider combination immunotherapy plus chemotherapy. So the last row on this slide is Checkmate 9LA, which is a combination of ipi-nivo plus just 2 cycles of chemotherapy. The chemo backbone is based off of the histology. This is kind of our newest kid on the block and one that several of us are just gaining experience with, but this is approved for any PD-L1 expression. And then the ipi-nivo continues for up to 2 years. The other options would be Keynote 42, which is for squamous patients, including this patient, would be carbo-taxol or carbo-nab-paclitaxel plus pembro, and the pembro continues for up to 2 years. I'd mentioned earlier, pembro monotherapy would be an option for this intermediate PD-L1 patient, although again, for most of us, that would not be the preferred option. So we'll skip ahead to the next slide. And again, this just kind of narrows it down to what this patient's options would be, more specifically Keynote 407 or IMpower. Go to the next slide. So just because it's kind of the newest kid on the block, Checkmate 9LA, to go through the study design, it randomized patients to chemo versus chemo plus placebo versus chemo plus ipi-nivo. The dosing was every 3 weeks of nivo, so a bit different than what we've seen in prior studies where the nivo was given Q2 weeks. Here it's a little bit better spaced out. It was a large study, randomized 1-to-1 of 719 patients. Patients were stratified by PDL1 of either PDL0 or PDL expression. They were also stratified by sex and histology. They continued until disease progression, unacceptable toxicity, or up to 2 years. And the primary endpoint was overall survival. Carla, if you could go to the next slide. And here is the primary endpoint, which is overall survival. And so we saw a pretty impressive improvement of overall survival of 10.9 months with the chemo group versus 15.6 months for the ipi-nivo chemo group, with a hazard ratio of 0.66. NJ, do you have any thoughts on this trial, or have you used this regimen yet?
So I think Checkmate 9LA, it has been a good option for some of my patients, in part because patients that have end organ damage, that, you are a little bit more nervous to continue the carboplatin for a little bit longer. I think particularly in patients that are in dialysis, it takes it's like planning a wedding, trying to do dialysis. Like, you have to make sure you get the drug to get the dialysis and the patient follows up, and you don't want to dialyze the agent. So it has allowed for these patients to have only 2 cycles, and the whole logistics and the challenges of being in and out of the hospital. And also have been helpful for some patients that have baseline neuropathy. I think, we have patients with diabetes, patients with other reasons for neuropathy. And while carboplatin is less than cisplatin, is still there, it still can worsen the neuropathy. So I think for these patients that don't have like a great organ function, has been a good option. And I think also, I work very close with my pulmonologist, and I think is that this regimen is different than the EP we all know, because EP has a bad reputation, right? Because we started with high doses of EP and melanoma, and many of our pulmonologists help us with this pneumonitis, bronchitis, then having in the ICU with pneumonitis or encephalitis, or call it adverse event due to ipilimumab. So I think EP has a bad reputation. But this new dose is different. It's every 6 weeks, it's 1 milligram, it's very different. So I hope that, sharing this today, we help some of the reputation of EP, and it's a very good regimen for these patients. And, these curves are obviously, there's benefit, and also you can see how they have flattened after like 18 months. And we see that with immunotherapy. Well, we also see a little bit with chemo, but they don't cross. And I used it 3 times and I have been very happy so far.
Excellent. And then let's go to the next slide. This is the breakdown of overall survival by PDL1, and I just want to point out that every group seemed to benefit here. So you've got at the top left, the PDL0 patients, very impressive improvement of 12-month overall survival from 45% to 63%. In the bottom left corner, we've got the moderate expressors of 1 to 49, and then we've got the high expressors at the bottom right. So again, I think showing that there's a home for this regimen regardless of PDL1 expression. And then next slide. And this is just the progression-free survival. Again, what we would have expected, seeing the overall survival, but an improvement with a hazard ratio of 0.68. And that's it.
Great. Well, for the sake of time, what we'd like for you to do, if you have any questions, is please put them in the box, and then we'll come back to them, or we'll stop. Just depends on how we'll check them out and see. Nice discussion. It's a challenging situation for these patients, but we're making progress. One last question I have for the 2 of you. Do you see these regimens becoming more less costly in the foreseeable future? Yes or no? We don't need to get political, but I mean, is there competition? Is there hope that we'll be able to see the reduction in costs?
I think if the initial Pembro nivolumab competition didn't make any big difference when there wasn't that many agents. I'm hopeful, but
the pharmaceutical companies are doing a good job of trying to help support so that people get them, and that's an important thing for people to know, that we can still insurance coverage, and then if people are out of coverage for some reason, the pharmaceutical companies are helping.
Yeah, I think the biggest difference we're starting to see in the cost of IOs is actually frequency of administration. So you see here that the Nivo is given every 3 weeks. Historically, we've given Nivo every 2 weeks. While the dosing or how many milligrams of Nivo you're giving isn't probably that different, it's less frequency of visits, fewer nursing administrations, things like that. So I think that is, we talked about positives of COVID earlier on. I think one of the things that COVID has really pushed us to do is to make these IO regimens more patient-centric and more patient-friendly with dosing frequency. And I think there's a concurrent benefit of cost to a lot of that.
That's so true, because the pembrolizumab every 6 weeks. I have a patient that drives here from Wisconsin to Florida. She wants to get her Pembro here, so she has 6 weeks. So she goes and comes back.
Amazing.
Amazing. That wasn't possible for a patient with lung cancer to get infusions every 6 weeks. And I think that we need to change the perception that patients need to be in the cancer center all the time if they don't have target mutations.
Yeah. Great. Well, let's go on to case number 2, Carla. Good discussion. So here's the second case. It's a 56-year-old gentleman, again, a smoker, who's unfortunately had problems with cough and shortness of breath. He's found to have the 3.2 right upper lobe mass that you see with some mediastinal hyaluronadenopathy. They do bronchoscopy and confirm involvement of station 4R. The PET scan shows no other distant metastasis, nor does the MRI of the head. Next slide, please. So which of the following would you do in your practice next? Multidisciplinary tumor board, surgical consultation, initiate chemotherapy and radiation, or just initiate immunotherapy? The poll is open. Please vote. We've got a few more people signed on to the webinar, which is nice. Those of you that are signed on just in the last few minutes, don't be shy. Pull up the polls and vote. Okay. So I'm going to give this one to Dr. Duma because I was supposed to give her the first one and I forgot. So I'm going to give both of these, but you'll get a chance, Dr. Besvina, to comment. So Dr. Duma, what do you think of the audience's response here?
Well, the first thing I think, the surgical consultation is the patient has a 4R lymph node, which is reducing the chances the patient can be a surgical candidate. But like my mentor would say, Dr. Molina, all of these options in some type of way are correct. Like there's always many factors that affect the response, but what is the one that to be most likely right? So initiate chemoradiation. In fact, it can be a good option, but we always recommend to bring the patient to the multidisciplinary tumor board. Why? Because there are many aspects that I continue to learn from my colleagues from radiation oncology before I tell the patient, oh yeah, you're going to get radiation. There are many, or patients are living longer, they have more cardiac histories, more lung issues, more challenges. So I think being to the multidisciplinary tumor board, we allow to, have a plan with the radiation oncologist, but also with the surgical oncologist to see, we explore any possible options. And I think it's extremely important that when we bring cases to the tumor board, it's not only for the immediate action, and a very big proponent that we discuss plan A, plan B, and several options after that. And that's what I think the benefit of bringing it to the multidisciplinary tumor board is like, is this patient has a performance status to do concurrent chemoradiation, or we're going to do sequential because the patient doesn't have the performance status. And I think we covered a lot of other aspects have taken into place. And the multidisciplinary tumor board is that there to like say, what can we do? Can he do radiation locally? Can he do chemotherapy with his local oncologist? And that's the benefit. So the correct answer is multidisciplinary tumor board. I think.
Carla, can you go to the next slide? And I'm just gonna make a comment and ask Dr. Duma, but this is the evidence. This is one of the guidelines that comes out or that stresses the importance. What percentage of your tumor board, time-wise, do you think is spent on stage 3A lung cancer?
Oh my God, I would
50%,
say
70%?
Oh my God, stage 3 is so controversial, and is you can ask a different surgeon every different day, and you may get a different answer, even from the same surgeon. There are many aspects that played into this.
You know, it's a rhetorical question. I admit it's a rhetorical question, but this is the value. And the point I want to make to our audience is if, you know, stage 4, okay, those are fairly clear cut, but yet still new therapies are coming. Early stage lung cancer in you know, community hospitals or smaller hospitals that don't have real robust tumor boards. But when you get to a stage 3A, that really requires, I think, not requires, but really is enhanced in the patient's outcome. And I think several studies have suggested that they do better if a multidisciplinary tumor board is brought to bear. So let's go to the next slide, Carla. So we talked about that. So then you go to the multidisciplinary tumor board, and which of the following do you think your tumor board is going to advise? So get the poll everywhere, and you guys think about this. So which one would you suspect your tumor board is going to say? Surgical resection after chemotherapy, immunotherapy alone, chemoradiation, or chemoradiation followed by immunotherapy? Please vote. I'm always curious. The one thing we don't have with Zoom is the ability to see our audience and to get a feeling for maybe how many are oncologists, pulmonologists, just what their specialties are. And that's part of the live that I miss, is getting to know the people that come to our programs. But we'll get back together one of these days. Come on now, don't hesitate. I see that less than half of you have committed yourselves. Just one or two more. I found like I'm an auctioneer trying to sell. All right, well, let's see. Okay, Dr. Duma?
All right, so we have a few proponents for the surgical resection after chemoradiation. I think those are very selective cases. We know that those patients, I specialize in young women with lung cancer, so sometimes depends on the case and the patient, but in this case, I think the patient may benefit more from chemoradiation followed by immunotherapy, because we know the recovery and the challenges of patients getting to surgery after chemoradiation, plus minus the surgical challenges after radiation of the lung. And that's something that you learn in the multidisciplinary tumor board, is like, you know, how challenging it would be for a surgeon to go and operate after a lung that has been radiated with 51 grays or 50 grays. Immunotherapy alone, I think we only set the patient and we treat him like a metastatic disease. So we won't give him that small percentage of having, you know, control of the disease and maybe a good response if we only treat them with immunotherapy. So we are setting him as a palliative patient if we only do immunotherapy. So the correct answer is chemoradiation followed by immunotherapy, and we're going to talk about why. But the chemoradiation for N2 disease is the appropriate and the one associated with better outcomes. Carla, can you move to the next slide to talk about the trial? So where this data came from? So the data comes from the Pacific trial. And the Pacific trial was like a big hit because we didn't have a lot of progress in a stage 3 disease for a long time, unresectable stage 3 disease. So prior to that, around 15% of patients were alive in around 5 years for this disease. Most of them have recurrence. But the Pacific trial adds immunotherapy after the patient has completed the chemoradiation. And the difference in progression-free survival, it means without the disease coming back, is 16.8 versus 5.6 months. I still remember seeing the data in an abstract, and it was such a big change in practice even before the paper fully came out, because there were no other options. We just watched these patients until they progress. And you know they were going to progress. So you were like, waiting for something that was coming. So there's benefit independent of PD-L1. 37% of the patients in the study did not have a PD-L1 status register because it was not mandatory. So next slide. The patients go and do durvalumab, which is a type of immunotherapy for 1 year, or onto disease progression or intolerability. The data was presented by Dr. Antonia about overall survival. We always have, mixed feelings about progression-free survival in adjuvant studies because some studies have proven that there is no benefit in overall survival, so the patients live the same, but they're getting more drug. But in this case, we did see that benefit in overall survival, in some cases up to 10, 11 months difference. And if you are a thoracic oncologist, that's a big deal. 10 to 11 months is a big deal. So the Pacific trial changed how we treat these patients and also how the conversation takes place in the multidisciplinary tumor board. And Dr. Edell and Dr. Besbina, you can confirm this. I remember going to the tumor board at Mayo when I was a trainee. Of course, 7 in the morning on a Monday. It was a different conversation. But how the conversation changed, because we have Durva, so we have something more to add to these patients. And it was like the surgeons were taking a step back because now the medical oncologists have more options for them.
Yeah.
Next slide.
Anything to add, Dr. Besbina?
I do think that it's changed. So I will say that at my institution, we do still really push for patients to get to surgery for those who have N2 disease, but it has changed our neoadjuvant approach for everybody. So historically, we would have managed the patient presented with probably chemo followed by surgical consideration. Now we really push for induction or actual treatment with chemoradiation up front, and we'll really push the dose to give 60 gray, which is a curative intent dosing. If the patient ends up being a surgical candidate with a nice response, then they'll go to surgery. If they do not have a good response and are no longer a surgical candidate, or that's taken off the table, then we've kind of appropriately hedged our bets and can switch to Durva, whereas historically those patients would have been left without any good options. So again, I think it's really just expanded our options for N2 disease.
Great.
And just to add, I think for the audience of pulmonologists, it also bring up high rates of pneumonitis that we had before, because these patients just finished radiation and then you put them in immunotherapy within 44 days. So we are seeing more of that. And I think you cannot treat pneumonitis without a pulmonologist. I think it's like hand by hand. And I have my pulmonologist and speed dial for these patients because they tend to be younger patients who are in a stage 3. Like I have a lot of young women and they have higher rates of pneumonitis. So these have changed, has made the relationship not only about tissue, because a lot of time was the discussions like, give me tissue, I need genomics. But now it's like, hey, I give this patient this drug. Sorry, can you help me now?
Yeah, and you really do need that by your side, because oftentimes it'll happen within the first 1 to 3 doses of Durva. So within the first month to 3 months, there's always a question of, is this radiation pneumonitis? Is this IO pneumonitis? Is this both? And how severe is it? And should we re-challenge? Because again, you're seeing here the benefits of Durva. I think the question of whether or not to re-challenge, depending on the severity of the pneumonitis, is a very relevant one.
Well, let me ask you a question about that, because this is now one of the more frequent things that we're seeing in this population. And I don't really feel that we have good evidence on how to manage these, to the point where here we're putting together a group multidisciplinary group that's actually creating another multidisciplinary clinic around these patients. Is it radiation-induced pneumonitis? Is it immunotherapy-induced pneumonitis? Is it infection or progression of disease? And I think that kind of evaluation, looking for some sort of biologic marker of immunotherapy-induced pneumonitis, may be something that will be helpful in the future. Either of you resonate with that concept?
I think what I always do for these patients is I talk to the radiologist, and sometimes I do a 3-way call, and I call the pulmonologist at the same time. One of the benefits of Friday clinic is there's not a lot of people around besides me and my patients. So it is important because the radiologist tells you this is in the field, this is not in the field, and the re-challenge.
I don't mean to interrupt you, Dr. Duma, but I want to respond to the audience. They've asked, how do we treat the pneumonitis? So let's assume that it's immunotherapy induced. What would be the treatment for that?
So both ASCO and ESMO have really nice immunotherapy-related adverse event guidelines where you pull up, you can Google it, you pull up the guidelines, it walks you through grade 1 pneumonitis, radiographic only, and then what do? You're okay to continue IO and just observe. Grade 2 pneumonitis, clinically significant. Should you just withhold IO? Should you go ahead and give steroids? So again, I think we're lucky to have pretty good guidelines at this point. For me, it depends on the patient's clinical severity and also kind of just clinical judgment. Is this somebody who really does need some steroids because I think they're going to continue to worsen? Can I just give them a break from IO? Can we watch? And exactly as Dr. Duma has said, I think co-management with a pulmonologist is essential here.
Yeah, so I think both Dr. Duma and Dr. Besvina just answered the question in the vein that this requires a little bit more than just what is it, how do you treat? It's not straightforward. Even with the guidelines, it requires some, as you said, some expertise, more input. I'm not certain that we start many steroids without making sure there's no infection. It seems like we do a lot of BALs to make sure, or at least sample the bronchial secretions, but more to come on that. Well, I guess we'll see. Well, good. Let's go on into our final case. This is a very interesting case that brings up many issues in the regard to managing these patients. You both have talked about your young patients, and I appreciate Dr. Duma bringing this one forward because we are seeing younger and younger, particularly women, with lung cancer, and it's worrisome. I don't understand it. I guess I should, but it is what it is. So this is a 38-year-old non-Hispanic white woman with a remote smoking history that presented with chest pain and diarrhea. She'd had recent travel. They did a CT angiogram, which showed focal consolidation 2 centimeter in the left lower lobe. Next slide, please, Carla. With that story, what would you do next? Would you biopsy the lesion? Would you follow up with a scan in 3 months? Would you do a PET scan? Or would you treat with antibiotics and follow up because of the limited smoking history? Please vote. When I end the polling, can you guys see the results of the polling on Zoom? You can, can't you?
We can.
And I think the audience can see them too, right? I'm hopeful. I just discovered a tab that said share polling, and I wasn't sure what that was with. And one of our participants said yes. Thank you. Now we're interacting. We've got people sending messages to us. Okay, well, let's see what the answer here is. Okay, Dr. Besvina, what do you think of the audience's response here?
So we have a 2 centimeter lesion. And so the most common option that was given here was biopsy of the lung lesion. I think she's certainly heading that way. I think the least most common answer was PET scan, which for me actually would probably have been my next step, was a lesion that's kind of in between that 1 to 3 centimeter, you certainly want to get a PET scan, make sure there's not any disease going on elsewhere. There's a follow-up CT scan in 3 months. One panel participant added that. I think just given the nature of the lesion, we're probably going to want to at least get some more information at this stage. And then the last one is treat with antibiotics and follow up because of remote or limited smoking history. I think one of the points that Dr. Duma has brought up a couple of times is seeing these younger women. And so, I think the more clinical experience that we get, I think we don't want to take the smoking history as much into account because of some of the driver mutation lung cancers and the complete lack of correlation with smoking history there. So
yeah. I mean, the index of suspicion here is very low. Most clinical, other than in a webinar about non-small cell lung cancer, you're going to kind of say, either A or D would be sort of the management. Okay. Carla, can you go to the next slide? Well, in someone who has that high index of suspicion, potentially, you can see that the evidence for going ahead and getting a PET scan is actually recommended. Now, that's a little bit, no one picked that because people, I think, would maybe move and say, come back. And if it's persisting, then they might do this. But I'm going to move this one up to say that this index of suspicion was a little bit higher and a PET scan was done. Because the PET scan can be picked up in both inflammatory as well as malignant disease. But the index of suspicion was worrisome. And that if it is, the next recommendation by all of our societies and guidelines that are out there recommend PET. So next slide, please, Carla. So here's the PET scan. And as often occurs, you see the primary lesion, not surprising, but we see other things. And you can see that there's diffuse uptake in the lateral left breast. And it's fairly decent uptake. Now, I'm sure that this person was interviewed and the history was taken and there was maybe a history of familial cancer or something that led to this high suspicion. And so if we're in this situation now, Dr. Besvina, what are you going to do?
So I think
your next step.
Yeah, you've got the option here of biopsying these things sequentially or just going for it all at once and comparing the histology of the breast versus the lung, because let's say you biopsy the breast first. If it's breast cancer, you're still not going to be sure that that's not a primary lung. Yeah. Vice versa. I certainly have seen lung cancer metastasize to the breast that I was sure was a breast primary, and it wasn't. It was metastatic lung. So being the person of lack of patience that I am, I'd probably go ahead and biopsy both concurrently.
Yeah. So next slide, Carla. And I think this brings up a very good point. When you have someone like this, and the guidelines would probably, if we'll put it in the intermediate, that getting tissue prior to going to a resection, at least just for the lung lesion, would be an appropriate next step. But also, as you can see here, an EBUS of the mediastinum would probably be correct, and then using at that time to go ahead and sample this with some sort of navigational technique. But clearly, getting the breast ruled out would be an essential part of that evaluation. Any comments to that, Dr. Duma?
I think this is very important because in young women, like we can see these changes in the PETs. And I think it's very important that, they're ruled out as breast cancer. Obviously, this patient, as you mentioned, doctor, they had a family history of breast cancer. But we needed to do with the biopsy to rule it out because it's still the most common cancer. Yes, more women are dying of lung cancer, but breast is still common. Yeah. So. And I have to say, like we discussed before, it also helps with the patient's anxiety and mental health, which it needs to be taken into account. Because I show you the PET and I say something is here, we uptake, but I'm just going to watch it. I think it's very hard for some patients.
Yeah, good
and
point.
Breast biopsies, thankfully, are easier to obtain than lung biopsies.
So let's go to the next slide, Carla. Let's see what people would do with this. So we have an adenocarcinoma of the lung. The remainder is okay. Would you do chemotherapy, surgical resection, chemo plus immunotherapy, or stereotactic body radiotherapy? Please vote. Dr. Duma, do you want to comment on the audience's response?
Sure thing. So we're going to start with the less popular and we go to the more popular. So stereotactic body radiotherapy in a patient that's 38 years old and doesn't have comorbidities, I think is not the appropriate option. But it is important to mention for some patients that had comorbidities and they're no surgical candidates, the data from Gomez, from MD Anderson has showed the benefit of these types of radiation. But 30-year-old, no past medical history, it would be not a good option. So chemotherapy plus immunotherapy. We didn't see any mediastinal uptake in the PET scan, and the biopsy didn't show lymph nodes. So meaning that the patient may or may not have locally advanced disease based on the clinical data, no surgical data. So this is unlikely to be beneficial in a patient that still has localized disease that in theory can be cured and resected. Chemoradiotherapy is the same along the same line. So the correct answer is surgical resection, but of course the patient should be discussed in a multidisciplinary tumor board.
Next slide, please, Carla. So go ahead, talk about what we found here, Dr. Duma.
So the patient underwent surgical resection, as the majority suggested. She was found to have a 2B disease, so M1 disease. And depends on who you read and who you follow, but you know, I'm the daughter of two surgeons, and the pathology, you really believe it's a pathology after the surgical resection, right? But the results show that EGFR exon 19, and the patient had a PD-L1 of 52%. Next slide.
Next slide, Carla. Now what we want to know is what people are going to do. So let's get the voting going. So we've resected it. She's got this expression. And if I remember right, Dr. Duma, no nodes were involved.
M1, she had an M1 disease.
Okay, so it's a 2A. Or was it a 2B?
2B.
It was a 2A, wasn't it?
2B.
2B, okay. We've got all 9 voting in now, okay. What do you think there, Dr. Duma? How do you like the audience's responses?
Well, I love the commitment to immunotherapy, but unfortunately, in this patient, right, there is no data to date about the role of immunotherapy in the adjuvant setting. We may have this conversation in a few years and maybe a role for it. But for patients that have target mutations like EGFR, ALK, we know they can have a high PD-L1 expression, but they have very low response to zero response to immunotherapy. And what this suggests is that these cases in lung cancer has become more complicated than it was in 2005, in which the answer was carboplatin and paclitaxel to everything. That no longer is the case. So immunotherapy is not a good option for patients with EGFR mutations. EGFR-directed therapy, there's new data that suggests that maybe that will be a good option. But for these patients, we are still recommending adjuvant chemotherapy because the patients are very young. There's a 4 to 6% benefit overall survival. But for a 30-year-old patient with no comorbidities, we're still recommending adjuvant chemotherapy followed by EGFR-directed therapy. And we're going to talk about that right next. Carla? So we're going to quickly talk about the Adora Trial. So the Adora Trial is the new kid in the block, and it was the exciting news for ASCO 2020. I often compare ASCO with Coachella. So the Adora Trial was the headliner of ASCO 2020, in which these patients that were resected with EGFR cancer were placed in osimertinib for 3 years. The study was unblinded early because great benefit in progression-free survival or disease-free survival, which is the primary endpoint. But it's important to mention that some patients got adjuvant chemotherapy and some patients did not. Next slide. So you don't have to know a lot about Kaplan-Meier's to know that these curves are separated, but it's disease-free survival. So there was a significant improvement in disease-free survival between the patients that went osimertinib or Tagrisso for 3 years versus the one that did not. Difference between 97 and 61% in 1 year. Next slide. But we have to be cautious about data. First, because it's disease-free survival. We have been here before. Gefitinib, which is another EGFR TKI, was very, very excited, and then we learned that there was no benefit in overall survival. But this is an option for younger patients. Most of them have very remote or non-smoking history. And to the point that even if you have a very light smoking history or any smoking history, adenocarcinomas need to have genomic testing. I'm going to make t-shirts. I'm going to sell them one of these days about that. Carla, if you can click next, the stage 1B, the benefit was marginal. So we have to have a very open conversation with the patients about the benefits of being an osimertinib, a drug that's $17,000 for 3 years. $17,000 a month, to be clear. So, but in a patient with a stage 2 and a stage 3, the data was more clear. So these patients are going now in osimertinib after adjuvant chemotherapy for around 3 years. Next slide.
Fantastic. Fantastic. Dr. Besvina, do you have anything to add on that case?
I agree with Dr. Duma. I think my enthusiasm for giving this patient adjuvant osimertinib after chemotherapy would be extremely high. I've had this conversation with 2 patients now since ASCO, and both patients were very eager to start on adjuvant osimertinib. I think when this data was presented at ASCO, there were certainly some naysayers who were skeptical about the lack of overall survival benefit being presented or being known at this point. But my sense is that the patient reception of this data is very different than the physician reception. So I'd say we're all pretty enthusiastic.
Well, it's amazing that we've come as far as we have, but yet we still have so much further to go to turn this disease into a chronic disease, as we've seen in breast cancer. But there is at least a glimmer at the end of the tunnel, which I can honestly say when I started my career, there wasn't. So very exciting. And I also am quite impressed how quickly this hour went. Being with the 2 of you has been very enjoyable. I continue, even though I know the slide deck, I learn from this format every time because some little nuance comes up. And I hope our audience has enjoyed it as much as I thank you both for your enthusiasm and your expertise. It's something that gives me hope for the future. I also want to thank again the American College of Chest Physicians and our corporate sponsor, Bristol Myers Squibb. Carla is going and doing her required finishing the slides, which I appreciate. The key learning points you'll see there. Fortunately, because of the American College of Chest Physicians, we're able to provide CME for this activity. So the instructions on the next slide, if you would go to the website, and you will ask to take a survey, answer some post webinar questions, and then you'll be given CME. So please, everyone, stay healthy, stay safe, wear your masks, vote tomorrow, and continue to do the great work that you do for the patients that come to see you each and every day. Dr. Besvina, Dr. Duma, thank you again very much. It's a real pleasure to have spent this time with you today. I look forward to seeing you in the near future without masks and able to address each other as friends as we did a year ago at this time.
Thank you so much for having us.